clinicians, and broader public health surveillance activities so we can advance monitoring and case management. Our department's interagency work group is also examining ways to enhance that surveillance, and currently the CDC estimates that only about 10% of new cases of viral hepatitis are reported each year. 2/3 of states report cases of chronic hepatitis C, but those that do have large backlogs of uninvestigated cases. And so a clear picture of the nature and scope of chronic hepatitis C in particular across every state is not readily available. So we plan to have better integration with respect to monitoring hepatitis and then implementing prevention and care programs. And we also want to address the disparities issue, especially how this condition affects Asian American and Pacific Islanders and African Americans and at-risk populations such as the homeless, immigrants, injection drug users, and incarcerated persons. So in summary, Mr. Chairman and distinguished committee members, we are very, very grateful to you for holding this hearing. We all agree on the tremendous burden of this disease on our society. I want to assure you that our department has taken immediate and coordinated steps to reverse the trends that are before us. We want to work closely together with you, and we have a major opportunity with respect to prevention and creating new systems of care. Again, I want to thank my colleague, Dr. Ward, who has done so much critical work in this area, and I'd be very happy to take any questions. Thank you.
Thank you very much for your testimony. Really appreciate your being here. Based on what you have seen, read, and heard, if we had the resources, can we prevent hepatitis?
Mr. Chairman, I think the potential for prevention here is unlimited, and we understand risk, and we understand the trends if we don't act. So we have a great opportunity right now with your leadership and the work of your committee. Also, I should stress that with the passage of health reform, we have an opportunity to talk about true systems of care and a renewed emphasis on prevention. Prevention involves not just work in the clinic, but also in the community. And in this particular case, prevention also focuses on immunization strategies as well. So we have tremendous opportunities right now.
Dr. Cole, if people don't feel sick and don't know they're sick, how can we go about identifying those who are infected?
So that's the challenge, Mr. Chairman, of screening of asymptomatic people, and that's the challenge of prevention, which we are facing much better as a nation. We have much more commitment and attention from policymakers like yourself, members of the health community, and the general public to advance prevention, testing high-risk groups, and screening. And again, through health reform that has a great prevention focus, we need more attention to developing guidelines for screening and testing high-risk groups, and then making those guidelines available for people to understand, and then also covering prevention services so that cost is not a barrier.
Right. How bad is the problem of hepatitis?
Well, we've heard the numbers over and over, up to 5.3 million people infected right now, but the big challenge is that up to 3/4 of people who are infected are unaware they even have the virus. So the challenge is catching it early for asymptomatic people, spreading the message that we have good treatments if cases are discovered early, sending the message through policymakers like yourself, and really changing the paradigm here with coordinated activity of all of you and then also within our department.
Right. As I understand it, the U.S. Preventative Task Force issues a directive to CMS as to what screening and treatment for hepatitis will be covered by Medicare. How can we make sure that the new treatments that you say are just over the horizon will be covered by Medicare if the task force issues its directive just before those treatments are ready?
Well, there are several parts to your question, Mr. Chairman. First of all, within Medicare and Medicaid, actually, there are new prevention opportunities afforded by health reform. So that's a very exciting part of this new law. And it gives us an opportunity to look at new prevention and screening strategies in a whole host of areas. The U.S. Preventive Services Task Force is, just to clarify, an independent advisory group of experts, and they are one of a number of groups that make screening guidelines. So we look to them, but also many other groups to come out with recommendations. So I'm hoping, again, that with this very important timing after health reform, with this hearing and with the establishment of our department interagency working group, we can bring all these prevention recommendations together and move forward as a country to tackle this major challenge.
Right. You know, I just want to clear up one other thing, too. That was a statement made in the last in reference to earmark. You know, my good friend who I work very closely with, you know, that this would not be an earmark. This would be an expanding a program that is in existence that needs additional resources in order to accomplish the goals that we all are seeking. So I just wanted to sort of make that clear. And so what we need to do is just fight to expand the program, which there's no question anybody and everybody you talk to is saying that we need additional resources. I now yield to the gentleman from California, Congressman Bill Bray, for 5 minutes.
Thank you, Mr. Chairman. And let me say, Mr. Chairman, as the representative of the 50th District, which has had a very checkered past when it comes to earmarks, I think this is one of those issues why we need to really talk about a true reform package so boundaries, lines are all drawn and everybody knows where the rules are. But that aside, I'd like to sort of engage the two gentlemen with some observations as a layman. First of all, for the record, I avoided tattoos not because of health problems, but because my father, who was a lifer in the Navy, assured me that he would take care of the tattoo with a rusty razor if I ever came home with one, okay? But I do worry about the fact that I see that mentality not being applied to the next generation, and that whole acceptance of certain behavior, some of it, you know, now totally acceptable, but does constitute still expanded risk. I'd like to see what we can do rather than just talking about how much money we can throw at the problem, which I think disproportionately we're not getting a fair share of on this issue. But aside from that, is that things like protocols for testing. I would strongly say that we need to get the word out to physicians that targeted populations should be looked at multidimensional, not just inquiring about behavior, but looking at the population, you know, window. When we've got that kind of number, any toxicologist and statistician will tell you, you don't ignore that kind of spike and that kind of opportunity. And so first of all, let me throw out some ideas as a layman. I'd go into it. If I was still at the county, I'd be telling our county physicians that you should not be asking them, how have you had risky behavior in the past, whatever, because that automatically sets off defensive mechanisms. And it's astonishing how those of us in the 50s and our 60s forget about our good old days when we lived through the 60s, which most of us can't remember anyways. But if we ask them, we basically look at their age, use the age as initial. Still, you can follow up on behavior for the general population, but as a backup, not necessary, because I just think that you got defenses. And the other issue is, right now, and I say this, I had the county physician because of a lot of exposure I had as a county supervisor. The Mexican border was on my district. I spent a lot of time in Mexico, and you know the horrendous problems with hepatitis south of the border. I was inoculated as much as possible at that time. But the treatment now that exists now is an IV treatment that is pretty extensive. It's how many weeks?
Up to 48 weeks, right.
Okay, the 48 weeks. One of the biggest problems I know, especially at a lot of at-risk population, is that when you talk about that kind of treatment, they may start the treatment, but the problem of finishing the treatment is always a big problem. The same kind of things we run into with antibiotics with certain populations. My question is, when you do this, you're doing your evaluation, update your 2004 protocols, are you looking at the new treatments coming down the pike that are being considered? Especially, I think there's about 3 different proposals for oral treatment that is much shorter. And it's a lot different going 7 weeks taking a pill than it is going 7 weeks going into a physician's facility and getting a shot. Are we looking at the fact of that the treatment effectiveness is going to jump dramatically if any one of these 3 becomes effective because the treatment of the deal? And is that going to be considered in our upgrade?
Sure, Congressman. First of all, thank you for your commitment to this. And we want the broadest possible approach here to advance prevention, education, and treatment all at the same time. So with respect to the prevention part, there is new effort and research to look at a so-called age-based model for identifying people at risk, and actually Dr. Ward at the CDC has led that effort, so I'm going to ask him to comment on that in just a second. And then also the treatments have advanced quite a bit, as you have noted, and it does have the potential to decrease the duration of treatment quite substantially for patients. So this is all good news coming down in the very near future, I hope, and we want to coordinate better identification of people at risk, whether it's risk-based assessment or age-based assessment, and we also want to advance better treatments. But I think Dr. Ward wants to say something about this.
No, good morning. No, we share your interest in looking at alternatives to our current strategies for screening. We want our screening approaches to be part of the solution and not part of the problem. And right now we have a fairly large body of evidence that risk-based approaches represent barriers to people getting screened in contrast to presenting opportunities. So what we've embarked upon is looking at an age-based approach, given that, to your point, upwards of about 3/4 of persons living with hepatitis C were born between 1946 and 1964, the so-called baby boom generation, and among that age group, about 1 out of every 30 people, or about 3% of persons in that age group, are hepatitis C infected. We would like to, and we have embarked upon a study known as BEST-C to see how we can, if this could be easily implementable by physicians. As we've already pointed out earlier today, hepatitis C is a major cause of liver cancer. We have other age-based prevention strategies for other types of cancer, breast cancer, colon cancer. So we would like to see how we could begin to look at hepatitis C screening in the context of cancer prevention and begin to say this is another age-based approach to protect someone's health for the future without requiring someone to go way back in the past and say this happened, so then I'm eligible for screening. We'd like to make it much more accessible and much more easily implementable by physicians, and in so doing decrease this large proportion of people who currently don't know their status.
Apologize.
Yeah,
But there is a big.
this gentleman's time has expired.
I appreciate it, Mr. Chairman. I just think that this this assessment from the update of the 2004, and the fact that it's a very complicated issue, and I hope sometime we can talk about it, about the fact of the difference of how expensive treatment is with IV, how there's people that will not complete treatment, as opposed to the new technologies come down, and how that affects the whole formula. Thank you.
Thank you, gentleman. Time has expired. Gentlewoman from California, Dr. Chu.
Thank you, Mr. Chair. First, I want to commend you, Dr. Koh, for taking on this disease so strongly. You are the first person in your position to raise this amount of awareness and activity on combating hepatitis B and C. So I truly commend you on that. It's a grave concern to me that in the U.S. hepatitis claims more lives each year than HIV/AIDS and is about 100 times more infectious than HIV, yet only 2% of CDC's prevention budget is devoted to hepatitis B and C. And it's also very disconcerting that Asian Americans are disproportionately impacted by this disease. Although APIs make up about 4.5% of the population.
Advise members they have 15 minutes to record their vote on the previous question to the rule providing for the further consideration of the small business.
Okay. Even though APIs make up about 5% of the U.S. population, they count for more than 50% of Americans who are living with the disease, and in fact, it remains a top killer of Asian Americans. Many of these Asian Americans have immigrated from countries in which they lack universal vaccination. They may have come here without knowledge that they were carrying the disease, and they may have already developed a liver cancer. Pregnant mothers can easily transmit the virus to their newborns, and that's how it's being spread. And it's so prevalent that in the API population, all of us know somebody who is infected. And in fact, recently in my area, the mayor of our local city died because it did develop into liver cancer. So my question is what you are doing to address the particular issues in the Asian American community with this incredible prevalence of this disease.
Well, first of all, Congresswoman, thank you for your leadership on not only this issue, but on so many issues for the Asian American and Pacific Islander community. I have seen your commitment personally, and I want to thank you for that. We understand that this condition of hepatitis disproportionately affects the Asian American and Pacific Islander population, so we have a lot of challenges ahead of us, but we also have opportunities. One opportunity, as you well know, is the President has established a new White House initiative on Asian Americans and Pacific Islanders. I had the great honor of standing with the President when he signed that executive order last fall in the White House. And the first meeting of that commission, which is co-chaired by Secretary Locke and Secretary Duncan, is next month in July. So we're going to put this issue on the agenda there to have the White House Commission address this squarely. Then we're also very lucky to have many leaders in the community, from the community health center organizations, advocacy groups, outreach efforts spearheaded by committed people from Asian American and Pacific Islander backgrounds, very involved here. And then also tremendous research that's going on. And Congressman, you and I attended a very important event where new health data was being released on Asian American populations. That was a great event to share in. So there's a lot more attention on documenting health concerns in our population, and then in mobilizing people who want to make a difference here. Go ahead.
Let me just add on to say, I think some of the critical areas of our prevention efforts as they relate to Asian Americans include our perinatal hepatitis B prevention program. As you pointed out, mother-to-child transmission is a major mode. It continues to result in transmissions, resulting in hundreds of infants becoming infected with hepatitis B. Many of those are Asian Americans. The number of women, as noted in our written testimony, has increased to about 24,000 per year who are hepatitis B infected giving birth. And currently our perinatal programs have the capacity to provide case management services for about 50% of those. We have the prevention tools to dramatically prevent transmission in this population through vaccination, hepatitis B, immunoglobulin, but those services have to be available.
And how are we going to ensure that the resources go towards this sort of effort?
Well, again, we are, I think, mobilizing every resource. Having this hearing is a tremendous statement of commitment from policy leaders across the country. We have this new energy from this department interagency work group. We have here at the hearing many people from community level and advocacy level who want to make a difference. Research continues to go forward, and then the health reform passage and implementation, I think, gives us opportunities to look at all these issues carefully and build a real system of care. As you heard from Dr. Ward, we're looking more closely on the screening strategies, and there are also new testing technologies that are being explored, rapid testing for hepatitis C in particular. I don't know if Dr. Ward wants to say more.
Well, I think the other critical areas, in general, but particularly as they relate to Asian Americans, is one is community awareness and education. Despite the high prevalences that you mentioned, awareness appears to be low based on the information we've received, and we need to correct that so that persons understand the benefits of vaccination and screening and early care rather than waiting for liver cancer to develop. And so we have done inventories to identify community organizations who are delivering prevention services for hepatitis B around the country. We've provided some resources to 2 areas to actually support screening for hepatitis B through those community organizations. So that's an important opportunity. The other critical area is provider education. If they're not going to a provider that knows what needs to be done for hepatitis, after you've increased their awareness, you really haven't done a full job. And so we have to link our community education with provider training so that when people go to a physician, that physician knows who should be screened, how to interpret the screening test, which sometimes can be complex, and then knows how to interpret that test result and determine who needs care and treatment for hepatitis.
But let me indicate to the members that we have 3 votes on. And of course, I want to yield to the gentleman from Missouri, and we try to finish up with this panel. And we will resume at 12:15. We'll come back at 12:15. Okay, so I now yield 5 minutes to the gentleman from Missouri.
Thank you, Mr. Chairman, and I will be more judicious with my 5 minutes, unlike my colleagues, seeing that there is a vote. Dr. Cole, I know that you've been very persistent about developing a interagency strategy to address this health crisis. In your view, what are some of the challenges that an initiative like this may face?
Well, we have a big department that has many responsibilities being put before us. When I arrived at the department last year, we had H1N1 ahead of us, and now, of course, we have health reform implementation. But the opportunity, I believe, is that we have really a unique and unprecedented chance to make a difference with respect to conditions like hepatitis, with respect to prevention and really building systems of care. Also, if I can say, we've had tremendous leaders in the department like Dr. Ward and officials at CDC. We've had work at agencies like NIH and the National Cancer Institute. Also, reimbursement discussions at the Centers for Medicare and Medicaid, but not that many chances to bring all those leaders in our department together to really see how we could work together. If I can say, the leaders at SAMHSA, the Substance Abuse and Mental Health Services Administration, and also HRSA, Health Resources Service Administration, we have pockets of activity, but now a real chance to bring everybody together and see how we can coordinate.
Do you
this.
have a working group?
Yes, we've met since January, Congressman, and I chaired those. Dr. Ward has been at every meeting. I should also acknowledge Rosie Henson, our senior advisor, who has been instrumental in launching this. And we have great commitment now across the department, and we're very proud of it.
And I realize that this administration does quite a bit with interagency strategies. And how has that worked in this case?
Well, we're going to focus within the department until October, and we get our internal coordination heightened, and then we are very eager to work across federal government and then particularly connect with community partners. Many community partners are here today, Congressman, and they've been working on these issues for a long time, and they have a lot to teach us. So we're looking forward to working and connecting all interested parties because this issue is so important.
Very good. Dr. Ward, according to the recent IOM report, African American adults have the highest rate of acute hepatitis B infection in the United States, and the highest rates of acute hepatitis B infection occur in the South. What does HHS plan on doing to address this population?
We have an elimination strategy for hepatitis B. We have a powerful prevention tool, hepatitis B vaccination. It's safe, it's effective. The nation committed itself to eliminating transmission of hepatitis B virus way back in 1992. We have made progress, as Representative Cassidy said. That was mainly around children. And over and above the mother-to-child transmission population that still needs to receive fuller attention, the other big gap in our immunization strategy is adults at risk for hepatitis B. And those low vaccination coverages are the major reason that African Americans continue to have high rates of hepatitis B.
And then there are many other disparities that exist within this epidemic, including greater rates of infection for many minority groups and the LGBT community. Are there specific strategies in place to address each of these groups? And if so, how does it differ?
Well, we've put out recommendations from CDC of which populations among adults need to receive hepatitis B vaccine, such as men who have sex with men, injection drug users, persons with multiple sex partners. We have, over the last several years, put out about $45 million in money to help public settings, STD clinics, local health departments, correctional facilities to receive hepatitis B vaccine at little or no cost, so that vaccine could be used to vaccinate populations which have been shown repeatedly over years to have low coverage, including the ones I just mentioned. So we would like to continue to advance improvements in vaccine coverage, which would then be followed by declines in hepatitis B. The other aspect of this is that African Americans also have high rates of hepatitis.
Dr. Ward, we have to cut you real short here
okay.
because we only have a minute and a half to vote. And of course,
He gives pretty long answers, Mr. Chairman.
Sorry.
well, that's what happened, huh?
Thank you.
We had to cut you short. But anyway, I want to thank both of you for your testimony. We're going to dismiss you, and of course, the committee will be in recess until 12:15, as close to 12:15 as we can. That we'll be back. But thank you so much for your testimony.
Thank you, Mr. Chairman.
Thank you very much.
Pleasure.
Okay.